Good evening, ladies and gentlemen. Thank you very much for inviting me to present myself to the Indian Association of Assistive Technologists. I'm grateful to Dr. Mukesh Doshi, your president, and Rajiv Verma, your secretary, and the team for giving me this opportunity to speak to this august audience. A broken body does not mean a broken person. And we are all committed to the well being of the persons who, for one reason or the other, are forced into facing this calamity. I would be restricting myself more to bladder and bowel care. Also, I would be restricting and limiting myself to down to earth solutions rather than going into the academics of it. We all know the effects of spinal cord abuse as per the level of infliction. Different set of symptoms for every individual ranging from muscular, sensory to neural effects. I would be talking more on the bladder and the bowel care. We are all well versed about the male anatomy with regards to urinary tract. The point especially to be noted is the length of the urethra, which needs to be handled with. Also, one should keep in mind the relation of the urethra to vas deferens, epididymis, and the testis. Urethra in females, as compared to male, is of a very short length, which in this matter is more advantageous. The role of this length of urethra will be more important once we proceed ahead. There is a situation wherein we all come across complete atonic bladder, which we call the neurogenic bladder. In some rare situations, and then at different phases of the injury, there is a lot of overactivity of the bladder where anticholinergic drugs work. Also, during sphincter damage, there is persistent dribbling. To tide over this situation, proper condom catheterization is the best possible solution. The tip of the condom is snipped off, and the nozzle of the urine bag tube is tied to the end of that condom by first reversing it. Then the condom is rolled over the penis, which is very lightly anchored to the base of the penis, avoiding extra pressure so that there is no penile edema. For female, I would recommend good adult diapers. The academic mainstay for diagnosing atonicity of the bladder is urodynamic study, which reveals flat detrusor curve with no activity. It is helpful to do this study for the diagnostic as well as for comparative purpose when repeated at a later date. It is very essential to drain atonic bladder, as otherwise this leads to chronic retention. Sometimes when it is retention overflow, a person does not realize it since he is convinced he is passing urine well, especially in the absence of pain. Retention overflow has a potential of becoming very grave in the absence of pain, as it may lead to over-distended bladder, along with hydroureters and hydronephrosis. When the situation is prolonged and thinning of the cortex starts because of hydrocalyx and the serum creatinine rises with fall in GFR, it may lead to renal failure. Though rare in this era and now less seen, but it is still observed. Catheterization of the bladder has a very long history, right from using rubber, plastic, and ultimately latex material. In older times, rich people used malleable silver tubes which they used to hide in the rim of their hats. This was more common for self dilatation, which was rampant because of post sexual misadventures leading to stricter urethra. Evidence of using hollow reeds, paper, metallic, and elastic gum tubes and bougies is also recorded. A small factor as it may sound, aseptic preparation for urethral catheterization is very important. If we want to make the life of these people already with compromise voiding dysfunction to be less miserable, it is very important to cover them up with an appropriate antiseptic so that there are very less chances of urinary tract infection. It feels very miserable to undergo all this along with an occasional painful scrotal swelling. Proper cleaning of the genital area with an antiseptic and draping it as per the norms is the mainstay of avoiding hospital induced urinary tract infection. Xylogen jelly used lavishly brings a dual effect of both the lubrication and local anesthesia. The habit of applying jelly to the catheter would be less preferable as compared to instilling the urethra with jelly. I prefer to first pierce and nozzle up the jelly before starting the catheterization. Best is to prepare a proper trolley for the same before starting the procedure. Having first sprayed the external genitals with betadine solution and draped the part, we should proceed ahead. Maintaining the decorum gives a tremendous feeling of safety and faith to the treating person. Insertion of jelly followed by catheter while talking to him or her makes the patient feel the procedure less strainful. I always show the patient jelly and the catheter before using them to gain their confidence and to make the experience less traumatic. No one likes anyone fiddling around with their genitals. But once you take out few more minutes and speak up with the patients, it helps in alleviating the fever. Catheters used are many. Malakots and J-code are no more used as better things are available. Foley's catheter are available now, which over the period of time have improvised tremendously, even qualitatively. They are available in all sizes, but more important than that is the size of the balloon. In acute retention cases with no sensory loss, it is better to use centric balloon rather than an eccentric one, as the previous one does not dig into the bladder, avoiding irritative symptoms. With improvised quality of the latex and improved manufacturing quality, the problems of rupturing of the balloon are rare, and so are the non deflation of the balloon. The mainstay of chronic retention bladder treatment initially would be the suprapubic catheterization. It is simple to do, easy to maintain, and buys time till other problems of spinal cord injury are taken care of. Also, an important factor is at the time you give a catheter trial, one should ask the patient to clamp. Say approximately after 2 hours, he should attempt to pass the urine. In case he does so, he should measure it and then declamp the suprapubic catheter. Keep a chart measuring both the outputs. In case the bladder is recovering, the volume of the natural passage of urine will increase, guiding the treating physician to decide whether it is time to remove the suprapubic catheter. Therefore, a catheter trial becomes very practical, less cumbersome, and result oriented attempt. As we are aware of the female urethra, it is very short. Suprapubic catheterization in female will be needed only in very moribund condition where you want to make of the life of the patient and their caretaker easy. Unlike female urethra, male urethra is quite significantly long. And in order to avoid urethral complications like injury, stricture, infection, etc., it would be recommended to have a suprapubic catheter, especially when the bladder drainage is needed to by supported over a significant period of time. What happens in chronic retention is the bladder is pushed up. You can see this there. This is the normal underfilled bladder, and this the bladder is full up. It is pushed up, and thereby the intestines are also pushed up. The intestines, along with the peritoneum, are also pushed up, assisting the surgeon to do the procedure, to do this procedure without causing injury to the bowel. Also, one must be careful that the trocar is not pushed too deep, or else it may injure the rectum. Best would be to do a suprapubic puncture under ultrasound guidance. Usual preparation of shaving, painting, draping is done. Role of local anesthesia is debatable since most of the people do not have any sensation. Anyone without sensorial loss injecting 2% lignocaine should suffice. Very good trocars are now available, ranging in size depending upon the size of the catheter required. Simple drainage of the bladder does not require very large size catheters. There are small caliber half moon trocar with cannula available. In fact, 20 years back, I commonly used an infant feeding tube. That was one of the cheapest. That was one of the reasons. It is important to cut the end of the catheter, even for Foley's, as that would subsequently help in threading the guide wire in case it is needed during subsequent changing of the catheter. In case of mucky or infected urine, wash can be given through that catheter. When we are in doubt about the quality of the retained urine in chronic retention, a three-way catheter can be kept for the purpose of irrigation. Suprapubic catheters, however good that may be, need to be changed every month or else they may lead to concretions and infection. See, you can see this so well. This is done under ultrasound guidance. Patient had a urethral catheter already. So what it was done is you make the bladder full through that urethral catheter, and now he's under ultrasound. First, he's checking under ultrasound guidance. With the knife, he's putting a small nick, and he is taking his own time so that there is no issues later on. Now he is going to use a suprapubic trocar cannula. See how he jabs it inside. He has checked it over the ultrasound that he is in a proper plane. It is usually 2 centimeters above the pubic symphysis. And once he is ready to put it inside, the suprapubic Foley's catheter is kept ready. There, he's put it in. You can see the gush of urine coming out there, and he's putting the Foley's catheter inside. Once it is in place, the balloon is inflated. You don't need to inflate balloon to the fullest. It is just to retain. and see how well you can see the balloon of the catheter, the track of the trocar, and the tip of the uh, catheter. You can see here the tip. It is so well seen. It makes the life very easy and comfortable for the surgeon also. Always remember, these patients need to be mobile and are not sick in true sense. They need good quality bags. Wonderful bags with non-returning valves are now easily available. Leg bags help them for their aesthetics by tying it on their legs. Not having to show that they have a catheter on them boosts up their morale. When they are in bed, you need to keep their drainage bags below the level of the bed. You don't keep it on the bed, you don't keep it on the floor. Otherwise, by chance the lock comes out, it makes things very messy. And patients are very innovative. They come up with wonderful ideas on how to keep the bag either on a stand or a hanger. See, a patient has used hanger. How easy it becomes to uh, hang it on the edge of the bed. Necessity becomes the mother of innovation or invention and creativity. Whenever there is chronic retention, see, remember one thing: whenever there is chronic retention, there is over distension. It is important to decompress the bladder very slowly. Initially, one can do that by keeping the level of the bed above the bed by at least 3 to 4 feet. Also, make sure that never more than 300 cc's is drained at a given time, at one go. Slowly, we can lower the level of the bag along the bed till it reaches the height of the bed, after which it can be kept at the ground level. Now, this is very important as it can sometimes bleed like hell. It can bleed very badly because of the sudden and the fast decompression, making miserable, full of tension. This is supposed to be because of capillary oozing. Having taken care of the acute and chronic situations, the mainstay and the best way to take care of bladder drainage is for the patient himself by self catheterization, or what we call clean intermittent catheterization. Once the person learns the basic technique, he is the best person to know his own urethra. I would always recommend himself doing it rather than different people going at different times and handling his urethra. It's more dangerous. If the person learns, he knows his urethra best. Female, once they learn, perform it very well since they have a very short urethra. Males also perform it very well. They are taught to sit at the edge of a sturdy table. Mostly, one CIC is done at the time of the bath. Cleaning of the outer genitalia is taught. A spray bottle of dilated betadine solution is used. Spirit is a big no, as there is a severe burning sensation if somebody by mistake applies spirit. Glands is cleaned in the male. A diluted Savlon pre-filled jar. Diluted Savlon pre-filled jar and jelly pierced and pre-nozzled. You have to first hold it up and then nozzle it up. So you do all this beforehand and keep it into that jar. Similarly, you have another jar with a little longer height where you can use the used catheters, and you need to use them till they are not softened. You can repeatedly use them. The catheter should not be used once it is soft. T-main catheter and with a, it has a stiff bended tip, or a Niletrin catheter can be used. See how wonderfully this person is emptying himself. I would just let you see how slowly, he is in no hurry because it is his urethra, it is his penis. He will not allow anybody to manhandle him, and he cannot do it himself. So now he is inserting a jelly. No, he uses full jelly. This this gives him a lot of satisfaction that he is lubricating it very well, and more than that, he knows it's not going to injure him. When he does it himself, it doesn't injure him. That's it. See how well he's taking his own time to do it. He was kind enough to record it for me. Now, from a jar, he's taking out an Elatance catheter. Slowly, he's putting it down. See, he is negotiating the curve. He has learned probably best than any other doctor. How wonderful. See, now if you can see, the urine has started coming out right up to this area. And sometimes when you put more jelly, it takes time to come out. The common question here is how much should be the length of the catheter inserted? The bottom line is that one stops as soon as the urine starts coming out. Once it is done, to wash the catheter in a running tap water so that the jelly, which is sticky, does not remain clinging to the insides of the catheter. This catheter, once clean, can be kept in a jar, as mentioned previously, for reuse. One of the common questions is how many times one needs to do a CIC. The obvious answer would be not to let the bladder overdistend, thereby needing at least 3 to 4 times a day. The ritual in the morning and before going to bed has to be abided to as much as possible so that it keeps the bladder empty. Good compliance gives a very clean and a hassle free life. Complications like UTI, etc., are known with catheterization, which can be avoided with due care and by respecting the bladder and the urethra. I think I've covered up in most of the questions about and the practical aspects of bladder care in paralytics. If there are any questions, you can either ask me or send them at pradeepganatra@gmail.com. I would also like to add a few words on bowel care. All said and done, we are rightly very conscious about our bowel habits. Sometimes we are told that he has spurts of liquid stool. We need to double check as they are not spurious diarrhea. A severely constipated person also throws out liquid stools by the sides. These are best managed by effective enema regularly. In the initial phase, if it has been there over a period of time, manual evacuation may be needed. See, if you when you ask somebody, he says, I'm passing stools very well. In fact, they are liquid. Now, that is an alarming sign. When they say that, because there may be a hard stool here, and because of your cremafin, etc., and all grandmother's solutions, he may be passing all liquid stools from the side, causing rise to spurious diarrhea. He may be constipated. So that is why a checkup, a per rectal examination with a follow up becomes very, very important. There are few aspects which I would like to touch during before I conclude my talk. These aspects would not be out of place here. Perineal hygiene is one of the most important mainstay of the well-being of a paraplegic bladder. a person. Clean and dry perineum solves a lot of problems, infective problems, fungal problems, skin problems, everything. Natural extension of affection, tenderness, and companionship between two people helps to feel sexually satisfied. And this is, I'm touching something very out of the way, but I think this is a very important because these people are not paralytic most of the time because of old age. They are young people. It may not be orgasmic. This sexual relation may not be orgasmic, but stimulation of the penis or vaginal introitus may be helpful in inducting reflexological arousal. Penile stimulation may occasionally, in some selected cases, may increase the length of the penis, which of course may not sustain erection or penetration. All the above discussed care has no value unless and until you don't talk enough with them, unless and until you don't listen to them and assist them to change their attitude to life into positivity. They need to feel belonged. I repeat, they need to feel belonged and to some extent needed in life to be nurtured by their near and dear ones. If we don't let them down, they bounce back in spite of anything and everything. There is always an inborn resilience in this class of people. See, the calamity which they have undergone, there is an inherent resistance, a very good resilience. They want to bounce back and they want to do better as compared to their contemporaries also. We need to take care of such people as a social responsibility. They need tons and tons of psychological support. When you see somebody like this, see how neat, clean, and involved he is with his environment. When you see this, your day is also made. You really feel you have worth something. In this photograph, I don't mind the names written here, which usually I don't do, because these are all newspaper reported cases. That lady, the paraplegics, see how they learn, and then somebody used to bring her for her treatment at the Jaha Rehabilitation Center. And what a lovely thing to do. They fell in love. Terrible. We think good people are not there in life. It's not true. Not only they fell in love, they got married. And natural to the extension of that marriage, they had a child. What a wonderful contribution by the team who took care of them. I really bow down to them. This is not easy. This is not easy. It much easier said than done. Janine Shepherd, she was a very aspiring Olympic skier. She was being trained to take part in skiing for Olympics. And then she was nearly killed when she was hit by a truck during a training bike ride. She was paralyzed and immobile for 6 months. She was given a very grim picture for recovery. But not only did she teach herself to fly, she became a professional pilot. Can you beat that? Can you beat that? This is what we have in us. This is what we have. And the famous sentence that I have been privileged to borrow from her is that a broken body is definitely not a broken person. What a lovely thing to say. There's a good TED talk. You can listen to her. Also, Deepa Malik, our own Indian, she's a paraplegic and she won a Olympic bronze medal. in discus throw, sorry, in shot put. She's also winner of discus throw and javelin throw. And what a proud moment, not only for her, for the Indians to see her carrying the Indian flag. What more can a medicine offer to you? This is a tremendous satisfaction of having seen this. A glimpse in the future. I would like to give myself a few words here on neuromodulation. See, a lot of work is going on in neuromodulation. A lot of work through the spinal root, and they try to uh, stimulate the nerves, see the effect. Lots of basic work is going on. We should look into that. Also, nerve regeneration. A very surprising article I read, I heard on TED Talk is the use of asparagus stem. You know, those injured nerves are stemmed like what we do in plants by a asparagus stem. And surprisingly, they saw the nerves being regenerated. And it is at a very advanced investigatory phase. I'm sure something new will come up, and this will generate a lot of not only interest, this will help the people who are affected by it. Andrew Pelling is the person who is involved in doing all this. And there are many more things like this coming up. I'm sure you know better than me, because I do a lot of other things other than this. And then what happens?
I'm Shyam
See
Bedekar
this.
from Baroda. This is an innovative chair I have developed, having a seat which will have number of options available. This seat is arranged in such a way that the whole top portion can be lifted and lowered with the help of a hydraulic effect. Number of options available will make life easier for the disabled ones or those old people who cannot get up from their bed on their own.
How wonderful. See, I'm trying not to say anything because I wanted just you to appreciate what is going on. You know how these cost effective innovations are in the forefront is very evident from that example. We have a lot of creative minds who render us very simple but effective solutions. Many among you I know are also very creative. This was one of the classic examples of the same. There are many such people, and also patients themselves teach us how they manage their problems. So simple but effective steps, making their life less miserable. There is one more thing which I would like to tell people is that you should present your things. You know, it is a must. You start from a local level, you go to national level, you go to international level, you'll become famous. But unless and until you don't publish those things which you are presenting in a peer reviewed index journal. The world doesn't know what you're doing. They know, but there is no recognition. One more important aspect that I would like to also bring it to everybody's attention is to patent it. Something which we have never done in our life. My hairs have grayed. We have never done it. But there are so many creative ideas and gadgets whom we don't patent it. There are there is a lot of support now available. Make sure you patent everything so that it helps recognize your talent and the Indian talent. Again, I am thankful to Dr. Mukesh Doshi, the president of the Indian Association of Assistive Technologists, and Rajiv Verma, the secretary, and other office bearers for giving me the wonderful opportunity to talk on this topic, where we not only contribute to the physical well being of the patient, but also mentally and socially to take care of those who come to us. I would urge the society to instigate people to go and do evidence based research and have primary Indian contribution to the world scenario. I'm also thankful to Jaya Rehabilitation Center. Somehow I always love to go to this place. And Muljibai Patel Urological Hospital. This is the, of course, the Bidra Sarvodaya Trust where Jaya Rehabilitation Center uh, is uh, is is there. I am also indebted to my patients who have taught me many more, much more than many of the books that I read. And of course, my team from the Muljibai Patel Neurological Hospital who helps me and supports me to do something very crazy ideas which I sometimes have. Thank you very much. You know, it's so wonderful to pee. So it is always better to make sure that you are not only you are passing urine well, you are making others also passing urine well. Thank you very much, all of you, for your patient listening. And I hope I have contributed something uh, to your knowledge with whatever little drops of my years of experience that I have. Thank you again and good night.